Good evening, everyone, and welcome to this evening webinar, a guideline update for extended endocrine therapy in hormone receptor positive early stage breast cancer. My name is Dr. Reshma Mahtani. I am Chief of Breast Medical Oncology at Miami Cancer Institute, Baptist Health, South Florida. It's my pleasure to be with you all this evening, and thank you for spending the next hour with me as I review the guideline update guideline updates for early stage breast cancer. And we are going to save questions till the end of the program. I promise we'll be finished promptly in 1 hour's time. I'm going to try to limit my comments to no more than 45 minutes, and that'll leave us, about 10 to 15 minutes for questions at the end. And you can put your questions in the chat box, and I'll be sure to address them all there at the end. Okay, so let's start by understanding the evolving landscape for extended endocrine therapy. And we'll start off by just stating what the issue is here. We know that a hallmark of recurrence patterns for hormone receptor positive, HER2 negative early stage breast cancer is this persistent risk of late recurrence. So many of our treatments have improved, and our ability to find tumors at an earlier stage has led to the vast majority of early stage breast cancers having an overall good prognosis, with several patients, the majority being disease-free and without an issue. And that's great news. But for the patients that do develop a recurrence, over 50% of these recurrences happen after 5 years. Back in 2017, there was actually a meta-analysis looking at over 63,000 women, and it demonstrated a persistent risk of distant recurrence after 5 years of endocrine therapy across all clinical pathologic groups, including even patients with small tumors that were node negative. And this, of course, was somewhat worrisome to see. But the challenge really is how to pick out these patients. And so this brings up the issue of, if many of these recurrences are happening later, well, why don't we just extend the endocrine therapy beyond 5 years? Our traditional time point is 5 years of endocrine therapy, but we know that some patients do benefit from longer durations. And what you see in this slide is a summary of consistent but inconclusive findings across trials in terms of who is actually benefiting. So let's go through some of these data sets that are summarized here. We see in the setting of patients who received tamoxifen initially in the adjuvant setting for 5 years, followed by an aromatase inhibitor or placebo for an additional 5 years. You see in the first 2 trials, MA17 and ABCSG, that strategy was investigated in a large number of patients, and we saw an absolute benefit in terms of disease-free survival of about 4.5% to 5%. And looking at patients that went on to receive 5 years of tamoxifen after an initial 5 years of tamoxifen, this strategy was investigated in the ATTOM and ATLAS trial. Again, large studies with over 3,000 patients. Again, a very consistent finding of about a 4% benefit. And then looking at the MA17R study, which is interesting because this is actually one of our longer duration or longest duration studies, because these patients had initially gotten up to 5 years of tamoxifen, followed by 5 years of an AI, and then were randomized to an additional 5 years of AI or placebo. So that's really looking at 15 years of endocrine therapy. Again, a large number of patients, almost 1,000 in that study, 4% benefit, and then B42, again, 4% benefit. So if you sum up all of these trials, we have 6 studies that are summarized here, including over 25,000 women, that show somewhere between a 3 to 5% additional absolute benefit from an additional 5 years of endocrine therapy to prevent any recurrence, because remember, disease-free survival events are not all distant recurrence. But what we do know is that 95% of women with early stage hormone receptor positive breast cancer do not benefit from this approach. And the challenge really is in identifying who these patients are. And so in that regard, oh, okay, so this just summarizes the comment I made. How do we identify which patients are among those likely to benefit versus those who are not? So in that regard, I'll bring up this very important issue, which in my practice is the subject of many conversations daily in my clinic, which relate to tolerability issues with endocrine therapy. And so here we know that endocrine therapy side effects impact quality of life. And we want to ensure that only those who are benefiting are the ones continuing on therapy, because we know that there are clear benefits in terms of decreases in local, regional, and metastatic recurrences. Of course, metastatic recurrences are generally not curable, and that would be something very important to prevent. But even in terms of some of the local recurrences or new events, this can be quite traumatic for many women who have gone through an early stage breast cancer diagnosis initially. And but we know, again, the consistent benefits that I showed you in the prior slide are on the order of about 3 to 5%. And what is assured are adverse side effects, because many women deal with the side effects that are summarized here in the middle of this slide, including bone toxicity. Some develop endometrial cancer, although low numbers, still this is something to worry about. Of course, venous thromboembolism and heart disease, and then the more common tolerability challenges, which again, I think are really from a quality of life standpoint impacting our patients even more than they admit to us, because when you look at adherence and compliance rates, you see that there are many women that are either stopping therapy, taking it inconsistently, filling prescriptions, but not really taking the medication. This is a real challenge for our patients. And here you see some of the tolerability challenges in terms of sexual side effects, joint issues, myalgias, cognitive impairment. So what tool do we have in our toolbox to try to figure out, who may benefit from endocrine therapy and what that woman's risk is of having a recurrence after 5 years of the initial endocrine therapy? Well, one genomic assay is uniquely positioned to support endocrine therapy decisions in this extended time period, and that's the breast cancer index, which is called a biomarker, but I really look at this as two biomarkers in one. It is intended to answer two specific questions. Is this patient's tumor biology likely to respond to additional anti-estrogen therapy? And this is based on a 2-gene ratio of HOXP13 to IL-17BR, which I would describe as really a molecular assessment of the estrogen signaling pathway. And by way of background, the idea that this gene ratio may be able to predict benefit from extended endocrine therapy was developed by a series of observations made by whole genome sequencing of patients who did and did not recur while on tamoxifen. The expression of these genes was found to be important and led to consideration of looking at this ratio, which I'll show you shortly in the next few slides, has been validated in multiple data sets. So the predictability of this assay is illustrated on the left of this slide, and I would say is really linked to the actionability of this test in clinic. And then the BCI prognostic part of the assay, that second biomarker that I talked about as its two biomarkers in one, is an algorithmic combination of 11 genes, which are illustrated here. So the two that I previously spoke to you about are incorporated in those 11 genes, the HOXP13 to IL-17BR ratio, but an additional 9 other genes are incorporated into this signature. And this is the prognostic component. It highlights the patient's individual risk of her cancer returning. So the topic of my talk tonight was really to update you on guideline updates. And so in the next few slides, I want to share some very important information with you about the breast cancer index being recognized by leading guidelines for extended endocrine therapy decision-making. And the first one is on the right, which is sort of hot off the presses from ASCO in April of 2022. And then NCCN had already previously endorsed this assay in January of 2021. So let's start with the ASCO inclusion. Here you see that BCI may be offered to patients with 0 to 3 positive nodes who have received 5 years of endocrine therapy without evidence of recurrence to guide decisions about extended endocrine therapy. And clinicians may offer the test to guide decisions about extended therapy with either tamoxifen and AI or a sequence of tamoxifen followed by AI. And what is also notable is that other assays, including Oncotype DX, EndoPredict, Prosigna, other biomarkers that we've looked into in the past, including Ki67 and IHC4, those were all felt to have insufficient evidence to predict benefit from extended endocrine therapy. And the ASCO guideline update recognizes the ability of BCI to help guide extended endocrine therapy. Again, this is as of April of this year. And then previously already endorsed by the NCCN, you see that there are a variety of gene expression assays that we use for consideration of adjuvant systemic therapy. They're all summarized here, but what I will point out is in terms of prediction of benefit of extended adjuvant endocrine therapy, BCI is the only assay here listed in that category. And then the other test that's considered predictive, which we routinely use for chemotherapy decision-making, is the Oncotype DX assay, which is listed as predictive for that decision as well. So here again, just summarized as we're focusing on guideline updates, NCC inclusion, and the treatment implications are just summarized here in a secondary analysis of the MA17 Trans-aTTom and IDEAL trials. Patients with hormone receptor positive T1 to T3 node negative or node positive patients who had a high BCI score. Again, that's that algorithmic combination of those two genes I reviewed with you previously. They demonstrated significant improvements in disease-free survival when adjuvant endocrine therapy was extended as compared to the control arm, whereas those patients with the low H/I ratio derived no benefit. And these studies were what validated the use of the assay in the predictive component, and we'll go through some of these data sets. Again, the NCCN has recognized this test as the only one available to predict extended endocrine therapy benefit. So what led to the inclusion in the guidelines, and what are the data sets that we can look at to support the recent guideline updates recognizing BCI for extended endocrine therapy decision-making? I like this slide because it gives you kind of an overall overview of the several studies that have evaluated BCI as a predictive tool. The first one, it was actually more of a proof of concept study, where here you see the Stockholm Breast Cancer Study Group trial, where there were over 2,000 patients initially in that entire cohort, somewhere in the late 70s through about 1990, and the question here was looking at adjuvant tamoxifen versus control. So patients were randomized between tamoxifen for 2 or 5 years or no adjuvant endocrine therapy. And even there, we were able to see this signal that patients that had a high H/I score had a 65% relative risk reduction versus those who had a H/I low. That was about 60 up to 62% of the patient cohort where samples were available to validate BCI, they showed no significant benefit. But now, of course, we're not looking to use the assay in that early stage first 5 years. It was more of proof of concept. What we're really focusing on is the studies that looked at that decision point later. And those are all summarized here in this table, and I'll go through these studies in detail with you: MA17, Trans-aTTom, IDEAL, and B42, which, as you look in this table summarized, what you see very consistently is the relative risk reduction that's been demonstrated across multiple trials now, involving a large number of patients, somewhere between 58 and 71% relative risk reduction noted when extending endocrine therapy with an additional 5 years, shown consistently. And you will notice that there's a little asterisk next to that 71% for B42, and we'll talk about that. It has to do with a time-dependent analysis that was required on that trial due to the curve separating later, and we'll go into that in a little bit. So let's go through some of these trials. The first is the MA17 validation study. As a reminder of the trial design, all patients had early stage breast cancer. They had received tamoxifen as initial treatment for 5 years, and then if disease-free, were randomized to letrozole versus placebo for an additional 5 years. And what you see summarized here is the absolute benefit from extended endocrine therapy in all patients, 4.6%. But if you look at those patients that had the high H/I score, it was actually a 16.5% absolute risk reduction versus the patients that had an H/I low score had no benefit. So it was these high ratio patients that were really driving the benefit. And summarized on the right-hand side of the slide is the relative risk reduction with a hazard ratio of 0.35, translating into a relative risk reduction of 65%, which was statistically significant. And then in the the Trans-aTTom validation study is shown here. Just as a reminder, again, the ATTom parent study was a very large trial of over 6,000, almost 7,000 patients in the UK that received 5 years of tamoxifen and then were randomized to continuing an additional 5 years to get to 10 years or to stop. And the Trans-aTTom study was a multi-institutional prospective retrospective study in which patients that had available formalin fixed paraffin embedded primary tumors were evaluated. And I just like to make the point here that these are all node positive patients, where I would say, you know, in clinic, our bias is really that, okay, this patient has a high risk of recurrence, she has node positive disease, and we would think that all of these patients would garner benefit. And here you see again that very consistent message summarized in the middle, 4.3%, all node positive patients again benefit from extending to an additional 5 years of tamoxifen, no benefit in the H/I low patients, but a 9.7% absolute benefit in the high patients with a hazard ratio of 0.33, relative risk reduction 67%. And then we look at the IDEAL trial, again, reviewing the study design, upfront tamoxifen or aromatase inhibitor for 5 years, or what we call the switching strategy, starting off with TAM, then going to AI. The parent trial again showed, so that was the initial 5 years. And then the extension part of this trial was 2.5 or 5 years of additional therapy with an AI. And again, the parent trial here, you see 4.9% absolute benefit in the group as a whole, no significant benefit in the H/I low patients, but a 9.8% absolute benefit from extended endocrine therapy in those patients with the high H/I score. And this is just illustrated here where I'll tell you, I think one of the important points about this trial is here you see a group of patients that had AI followed by AI, which is something that we're more and more increasingly doing in clinic, where we have patients that are perhaps postmenopausal at presentation, but have high risk disease. And we're thinking of doing the entire 10 years of aromatase inhibitor therapy. So here was the carry on. This was the validation study from Ideal. And again, the relative risk reduction coming out again to 66%. And then finally, we'll get to the B42 study. And so here, this was an interesting trial. There were almost 4,000 patients treated initially with either 5 years of an AI or tamoxifen followed by AI, randomized to continue endocrine therapy for an additional 5 years versus placebo for that additional 5 years. And just as a reminder, when the trial was initially reported, it was first a negative study. There was longer follow-up that was needed. Eventually, we saw this 3.3% absolute benefit noted in the patients that had 10 years of treatment. And the distant recurrence absolute benefit was quite low, as you see illustrated here. So there were some challenges with regards to this translational study of B42, where BCI was validated. The first point that I'll just make is that there was a bit of a statistical hit that was taken with the numbers. The translational cohort that was available was a lower risk population. There were a lower number of events where there is then challenges with underpowering of the analysis and the lack of ability to have enough events to see a difference. All the samples were also not available. I did make the point that this was first a negative study, and most of the events that we actually saw here were contralateral new primaries, where BCI is not indeed intended or designed or developed in order to show an impact on new events. And what you see here in the parent trial is, again, remember that it was originally negative, and then with longer follow-up, you started to see the separation of the curves. And that has to do with that carryover effect that we know happens with the first 5 years of endocrine therapy, with the curves not separating until year 4. And the proportional hazard assumption was not met. So there was a time-dependent analysis that was done, and there was also a statistically significant extended benefit for distant recurrence prevention, similar to what was seen in prior studies. But there are some nuances to this trial that just warrant consideration. And see here, again, as I mentioned, consistent with previous studies in this time-dependent analysis, there was a significant benefit seen, relative risk reduction here, 71%, as shown. So what we have seen with the predictive studies that I just went through was a very consistent finding of identifying patients who are of the potential to benefit from continuing endocrine therapy. But again, as I mentioned initially, there is a prognostic ability of this assay as well, in terms of just identifying what that risk is. And I think this is a really important point to make with patients and share this information, because I think women, when they're originally diagnosed with breast cancer, their biggest fear is having a recurrence. And sometimes in their mind, they may overinflate what that risk is. And sometimes these decisions about whether to extend therapy or not, from the standpoint of the woman who is making that decision, she may make it based on fear, based on amplified risk in her mind. And so the ability of an assay to actually quantify that risk, I think, has been really useful in my practice, to have those conversations in a way where women are able to think of it differently when they have that number. And so the prognostic evidence has been demonstrated, the validation of the breast cancer index across 4 trials in both node negative and node positive patients. And you see those slides or those studies summarized here. For the node negative validation, there was the Stockholm randomized controlled trial, including postmenopausal women, 317 patients, a multi-institutional cohort study across various institutions that included pre and postmenopausal women, and then in a group of patients that had received tamoxifen or an aromatase inhibitor and Trans-aTTom, and in the node positive patients, again, pre and postmenopausal tamoxifen or AI. So what we see when we look at the groups of patients that were studied in these trials is a diverse group of women that are both pre and postmenopausal, that are treated with tamoxifen or an aromatase inhibitor or some combination. And so I think this is, again, very reassuring when it comes to the applicability of the test information for the patient in front of you. So that's a nice segue into the next section, which is understanding and applying the breast cancer index results. So this is the way the actual test result comes to you. And I actually share this with patients. I credit the company for looking very carefully at their test result and going through multiple iterations of how to best present that information to a patient. Previously, there was this high or low number, or high or low reported for the prognostic result. And I think that became a little bit difficult because once a woman just saw that value or that word high, my risk is high, everything else almost shut down. And so, as I pointed out earlier, I think the newest iteration of the test result, where there's actually a percentage that is shown there, I think is much more useful and has been in my practice, because here you see, again, what is my specific risk of late distant recurrence, or that prognostic ability of the test, and it's reported as a percentage. And of course, all women perceive risk differently, right? So we have to draw the line in the sand somewhere. If it's over about 5%, it's considered high risk, but that number can mean different things to different women. And then, of course, the predictive ability of the test, that H/I ratio, is very simply reported as a yes or a no. So I think in terms of having the conversation with the patient, it becomes very simple. Of course, we understand how this test has been validated and the strength of the studies, but when we're presenting the information to patients, we have to make it, of course, very clear and simple for them. Across trials, patients identified as yes, likely to benefit, experienced a 58 to 67% relative risk reduction with a full 10 years of treatment. And here you see an opposite result, where you see for the prognostic a very low number, and then you see no benefit. And of course, I would say that these test results and the 4 different options that you can have in terms of a high prognostic result or a low prognostic result, and then a yes or a no for the predictive, of course, it can be in various different orders. And I think in my practice, I have not used this test as something to say, okay, this is the decision we're making, and we're going to push that result across the table and say, okay, this test tells us definitively what to do. But it's been very useful in starting the conversation to help a woman understand how high is her risk. Is she benefiting? Is she not benefiting? What are her toxicities? And use all of that information to help come to a shared decision with that patient in front of you. And so now we shift to a discussion on the impact on clinical practice, a shift to standardizing extended endocrine therapy recommendations based on the appropriate tools. So here's something that I think is really kind of eye-opening, and that has to do with what our assumptions are based on clinical pathologic factors and how those can be incorrectly used to mis-categorize patients. So I think when I was going through one of the earlier data sets, I made a mention of it being a node positive study where our kind of bias or our pre-assumption is that patient is going to benefit from extended endocrine therapy. But here you see a genomic evaluation with BCI provides greater value in identifying which patients may benefit. And in this data set, you saw that even in patients that had high risk disease, anyone with node positive disease, we consider clinically high risk. When BCI was applied to that data set, they identified 22% as having limited risk of late recurrence and 69% not likely to benefit from extended endocrine therapy. So it makes you kind of pause and think, well, do all node positive patients really benefit? And is their risk really as high as we think it is? And I think we're starting to recognize that also, even in the early stage setting, when we're now backing off from giving chemotherapy to carefully selected patients with N1 disease, based on other genomic assays. And so I think this whole issue of using clinical and pathologic features alone is something that we're looking at and reevaluating in all of our decision points in early stage breast cancer. And then on the flip side, you see that patient that you would assume is going to have a very good outcome. And maybe in select cases, we are actually undertreating those patients. Here you see that BCI identified 25% in this data set of node negative patients as having a higher risk of late recurrence and likely to benefit. So kind of eye-opening when you get these results. So we know that clinical pathologic features alone are insufficient in predicting benefit from extended endocrine therapy. And this is highlighted here based on, some risk factors where we would think larger tumors, node positive patients would normally receive longer durations of therapy. Even within this high risk subset, there are patients that have H/I low results that derive no benefit of extended endocrine therapy and are likely to experience significant side effects, and they're likely being overtreated. And so that's the point that we're making here in this slide. What we also know is that quantitative ER and PR show no significant correlation with benefit. And this is something that I think we were previously looking at as a potential biomarker, but when evaluated here in this analysis that was published in the Annals of Oncology, we saw that only BCI and specifically that 2-gene ratio correlated with extended endocrine therapy benefit. So I think there is a nice kind of group of assays now that we can use to help us make decisions in both that early stage time point, but recognizing that assays like Oncotype may give us an overall 10-year risk, but when we're really looking at that late time period, we see in a multivariate analysis here a comparative performance of BCI versus the 21 gene assay in the Trans-aTTom cohort. We really saw the ability of the BCI signature to pick out that decision point that's the late recurrence decision point. What is the risk in that late time period, and understanding the strength of BCI in terms of the prognostic ability to show that late distant recurrence. And by late, we're talking about, again, that 5 to 10 year time point. So how has this assay fared in terms of impacting clinical practice? Here we get into a session on impact on physician treatment recommendations and patient compliance. There was a Yale UPMC decision impact paper that showed that when patients received or underwent BCI testing and that result was reviewed, it changed the physician treatment recommendations regarding extended endocrine therapy in about 30% of patients. So the flip side of that, I guess the way I look at it is that in about 70% of the time, we might be guessing pretty well in terms of how risk node positivity and things translate into the results we see. But a third of patients, or a third of the time, I should say, according to this impact study, those assumptions were actually challenged and decisions were changed. So I think this is a very clinically meaningful result. And of course, I did allude to this earlier when I talked about some of the compliance and adherence issues that we know we're having as patients are suffering from the toxicities of these therapies. And here you see some of the reasons for discontinuation in an analysis done by Dawn Hirschman. Of course, 40% side effects, but you look at some of the other issues that come up. They're worried about the risks of the medication itself. They just don't feel good on it. They weren't sure if it was doing anything. Cost, financial toxicity, treatment-related fatigue, treatment fatigue, especially as we're looking at using chemotherapy, using other drugs in the early stage setting. Now there's data for bisphosphonates and rank ligand inhibitors. So we throw a lot of therapy at patients in the early stage setting, and having an ability to identify who's really getting benefit, I think, is very important when it comes to keeping patients motivated because they understand what benefit they're getting. And we know that poor compliance negatively affects outcomes, as shown in this slide on the right, where not sticking with the treatment plan in the adjuvant setting was associated with worse patient outcomes. Here we see an analysis looking at impact on patient compliance and joint decision-making. 82% of patients recommended for extended endocrine therapy stated they would be more likely to be compliant based on BCI results. I hear this in my practice a lot, where patients ask for advice and they say, well, I don't want therapy, but I'll take it if I have to. And I don't think anyone really has to, but having a tool to communicate what risk is and what benefit is kind of answers that question, because sometimes we get results where the risk is so high and the benefit is present. The patient themselves answers that question. They say for themselves, well, I guess I have to. And in that way, they're part of the decision-making team. And I think that's what we're really aiming for, ultimately, to have that patient a partner in our decision-making and not make it feel to them like we're just guiding the treatment plan without their input. And here you see, again, both physicians and patient decisional conflicts significantly decreased. I don't like the thought of having conflicts with my patients. I like to be able to come to a decision together that we're all comfortable with. So as we integrate BCI into clinical practice, here you just see a nice summary, again, that it's intended to inform the decision of extended endocrine therapy beyond 5 years for early stage hormone receptor positive breast cancer patients. It's the most validated commercially available test that predicts benefit of extended endocrine therapy beyond 5 years, making it the best tool to determine the extension of treatment. That predictive component of the test is what really does highlight it or differentiate it from some of the other assays that we have available specifically in this space. And it's, again, as the point of this presentation this evening was to, again, highlight the update in the guidelines. Only BCI is recognized by ASCO and NCCN guidelines to help guide extended endocrine therapy. So there are, of course, intended limitations and uses. It's indicated for women with ER positive, lymph node negative, or lymph node positive disease. Lymph node positive meaning up to 3 positive nodes. Of course, we would like to have data in an even higher risk subset to de-escalate therapies, but I don't think we're there yet. And so certainly I wouldn't, in my practice, use it in a patient with more positive nodes than 3 to forego extended endocrine therapy. Of course, these patients have to be distant recurrence free when we're making this decision. It provides quantitative estimates for both late post 5 years from diagnosis distant recurrence and the cumulative distant recurrence over that 10-year period. And the predictive component of the assay, again, is highlighted here. It was developed, it's not been cleared or approved by the US FDA. It's intended for clinical purposes, can't be regarded as experimental or investigational. So I'll let you read all the fine print here. Okay, indicated for use when the patient is, and again, I think I've made these points clearly throughout this evening, but just again summarized here: pre and postmenopausal, node negative, node positive, tumor size up to T3, all grades, HER2 positive and HER2 negative. I think the data with HER2 positive disease, that those data sets are smaller, but certainly there are some data in triple positive patients as well, and we can talk about that a little bit later if anyone has a question. ER positive and or PR positive, chemo treated or untreated. Again, these patients are disease-free when we're making the decision, and without regards to histology. So the last few minutes, I'll just go through a couple cases. And here, these are not cases from my practice, but I think they're very common clinical scenarios that we all see very frequently in our clinic. Here you see a patient who's 63 with a lymph node negative 1.1 centimeter tumor with grade 3, which is of course worrisome. ER and PR highly positive, HER2 negative. And here we don't know what she received in that first 5 years in terms of endocrine therapy. I guess in my practice, I would be thinking about giving this patient an aromatase inhibitor. She's postmenopausal, and we know that aromatase inhibitors are slightly superior to tamoxifen in that setting. So here the decision about whether to extend or not was made based on the breast cancer index result, which did show a fairly significant risk of late distant recurrence, 9.7%, but unfortunately no predictive benefit result from extending. So I think, in terms of how the conversations go, this is a little bit of a tough one because of course, when a woman sees that her risk is, on the higher side, but it says no likelihood of benefit, it does make the conversation a bit challenging. I do start to talk to patients about other things that they can do in terms of lifestyle modification, limiting alcohol intake, weight loss, and things of that sort. Sometimes in this situation, I've still decided to continue the patient on if she's just feeling more comfortable and tolerating the treatment well, but certainly one of the tougher responses or results to get. And then here we have a 55-year-old lymph node negative patient, again, ER/PR positive, HER2 negative, and her risk is relatively on the lower side, less than 5%, but an absolute benefit that again could be if you take this and just make it, for ease of numbers, you're getting about a 2/3 risk reduction here. So you have a small number to start with, but if you take 2/3 of 5%, you're now getting into really low numbers. But if the patient's tolerating the treatment well and is highly motivated to continue, it wouldn't be unreasonable to continue there. And then of course, here's the result where you see a patient who has lymph node positive disease, who's on the younger side and has a tumor that's again ER positive, PR negative. So that makes you worry about that luminal B phenotype, maybe something a little bit more aggressive, grade 2, and lymph node positive. And at the 5.5-year mark, she receives BCI testing and has a high prognostic result with an 11.1% risk of late distant recurrence. But the good news is we can do something to get that risk down. So just again, for ease of numbers, if it was like 15%, I would be saying we can get that down to like closer to 5% with that 2/3 relative risk reduction. And here you just do the math, but you're getting into single digit numbers when you're able to apply that relative risk reduction to a number that's this high. I think that's my last slide. I'm going to stop sharing my screen and look to see if there are questions that have come through. Okay, so one question came through where we see it's listed, or it's stated, why is BCI the best test for extended hormonal therapy? Well, I think that was the whole point of the presentation this evening, to just go through the data that validated the breast cancer index and the studies that showed that very consistent relative risk reduction of about 65% when you apply that 2-gene ratio. And I think that is something that's unique for the breast cancer index. And again, the point of this evening's presentation was to highlight the fact that NCCN and ASCO, who these guideline panels are very clear in endorsing assays where we have the highest level of evidence, and BCI has been designated as the only assay to help make that decision based on the data sets that we went through. So here's another question. Is there any element or genetic signal common to the patients who are predicted to benefit from extended therapy but recur anyway? I think that's a great question. I think it's an unanswered one at present, certainly an area that we need to do more work in investigating what is the biology of that disease. And I think as we look at patients that go through extended endocrine therapy, of course, these are risk reductions. We can't get a patient down to a 0% risk of reduction. What is driving that recurrence, even when patients have extended endocrine therapy on board? I think that has to do with other pathways that may be at play and are certainly under investigation in clinical trials and from a translational science standpoint. So is BCI covered by insurance? Yes, it is covered by insurance. And I think that the team at the company is very helpful in going through any sort of insurance issues that you may have. Of course, I would point you in the direction of the company to help answer any coverage questions. But I can just tell you, having used this test for many, many years, I have not had an issue where a patient has had to pay a large out-of-pocket. The company has been very good at working with patients in that. What is needed for the BCI test? Okay, so the test is actually done on the tumor specimen. So this isn't a blood test. This is something where we order the test, and the company works with the pathology lab to obtain the specimen and get it sent to the reference lab where the testing is done, and then the report is provided to the physician. Would you briefly explain the biology of the test and how to talk to patients about how this test works? Again, I think, the language that we use to communicate what this test tells us and the decisions that it can help us make are very, very important. So I think it's a very good question. I think the first thing that we have to do is assess the person in front of us, and at what level explanation they're looking for. I think most women on a very basic level are trying to understand whether or not they're going to get benefit, and whether or not their risk is high enough to warrant the additional toxic side effects. So in my practice, the way I usually point to this or bring up this conversation is somewhere around the time point where patients are starting to ask me, well, how long am I going to be on this? That's usually, around the 4-year mark. Some patients, it's very clear that I might even considering extending upfront. So if they had multiple positive nodes, I might tell them right from the get-go that, listen, your likelihood is going to be higher. If they had 5, 6, 7 positive nodes, I would say definitely we're going to extend you. If they were in that time, in that frame where they had up to N1 node positive disease, I would tell them that we're going to be ordering a test to help us make the decision. When we get to around that 4-year mark, I start to bring up the test again. Again, talk to them about how they're tolerating the therapy, looking at tolerance issues, bringing up other tolerance things that sometimes patients don't like bringing up, like sexual side effects. They're very shy to bring those up. We look at bone density, we look at other tolerability issues, and then we decide whether or not that woman is already in her mind, has it been made up? And is that decision something that she would reconsider if she was given further information? Certain patients, they say, you know, I don't care what you show me. I'm not coming off of this medicine. It's not bothering me. And I'm really, really nervous. And in those patients, I might not even order the test. If they're doing well, they're not having any tolerance issue, their bone density is good, and they're very, very inclined to continue, I may not order the test. Conversely, if there's a woman who says, I don't care what you tell me, I'm not taking this medicine. You can show me what my risk is, you know, sky high. I'm coming off of this. I don't know that I would be able to convince her, but I think those two extremes are usually not the case. Most of the time, I think women are very open to hearing more information about what their risk is and about hearing whether or not they're going to benefit. And the way I explain the test is this is going to answer those two questions. And before we even get the result, I give them what the scenarios could be. Your risk could be on the higher side. You could have benefit. That means that you have a high risk, but we can get it down by about 2/3. Or you could have a low risk and we could make that number even lower if the predicted benefit is high. And then I have the conversation on the other side. So I think the decisions that we make nowadays are described as shared decision making, which I kind of like that term because I think a patient should always be part of the decision making. Ultimately, it's going to be that individual who's going to be carrying out our treatment recommendations and has to suffer the toxicities of those therapies. So she most certainly should be involved in those decisions. So, you know, this test was here. There's a question that came through. Can we extend hormonal therapy beyond 10 years? In my practice, I usually don't go that route unless someone's got very, very high risk disease with, you know, N2, N3 disease. Of course, you know, if you look at that MA17R study, I showed you the schema there. It's not that there isn't data to go up to 15 years in some patients, but those would be a very few select patients. The majority of my patients, I think, as I get to that 5-year mark, I'm making the decision about getting to year 10 and then stopping at that point. Let me see if I missed any. So one question as I'm scrolling back through that I did miss, but was addressed in the presentation again, was were any other hormonal therapy studied besides tamoxifen? Yes, there were patients that had received 5 years of tamoxifen followed by an additional 5 of TAM. That was Atlas and ATTom that we had gone through. But again, and you know, those other data sets that we looked at, MA17 and IDEAL, especially those patients had 10 years of AI in one arm of IDEAL. So the test has been validated in both pre and postmenopausal patients, node positive, node negative, and with different treatment hormonal therapies, including tamoxifen and aromatase inhibitors. Well, I don't see any more questions coming through the chat. No other questions. Okay. All right. So with that, I will give you guys back a few minutes of your evening. I hope the program was educational for you. If you have any further questions, the team at Total Health has my permission to share my email. I'd be happy to collaborate with any of you on any questions that you may have about using the test or just general breast cancer questions. Always happy to help. Thank you so much for your time.